This morning of number one, starting you off, getting folks excited and ready to go. And I'm going to talk a little bit about the top 10 things that I get asked by addiction med docs about infectious diseases. So I'm a family doctor and I'm board certified in addiction medicine. I actually did my formal fellowship training in HIV and viral hepatitis. But I did it up in Lawrence, and so there was a huge amount of overlap with addiction medicine as well. And now I work doing about half primary care and about half consultative care for folks with HIV, chronic viral hep, and also substance use disorders. What are my disclosures? I have no financial disclosures, but I'd love some if you know anybody. And I am not, in fact, an infectious disease specialist. I'm a certified HIV provider, but because of the work that I do, I tend to field a ton of questions about infectious diseases. And so my answers to questions may not be what you get from your local community ID docs. And so I'm hoping to share that perspective. I also really enjoy memes, in particular, The Simpsons and Family Guy. I grew up in Massachusetts, and if anyone knows Family Guy, my mother is literally just Lois. You're going to be having some sort of a problem. Great. Oh, wonderful. The other disclosure that I will make, right, I sort of boasted these are my sort of top 10 questions, but it is impossible to go through 10 things in 30 minutes, and so I am going to cheat a little bit. So what are our objectives? I think my first major objective I want to give to you all, I want to increase a bit of your comfort with some non-ideal infectious disease scenarios, in particular related to chronic viral infections. And then also solidify the fact that you all as addiction med type folks are actually really good at infectious diseases, more so than many of your colleagues. And you actually already have a ton of exceptional ID knowledge. And I just want to kind of bring that forward. So question number one, should I stop this patient's ART? This is the most common question that I get. And the answer is probably not. When do I stop ART? There are actually a couple of scenarios where we might consider acutely stopping someone's antiretroviral therapy. The first one is an acute toxicity from the ART itself. In the year of our Lord 2024, we are using very, very benign antiretrovirals that have very minimal toxicity. And so this is very seldom actually the case. The only time we really truly see this is if somebody is on a tenofovir-containing regimen and is developing an acute Fanconi syndrome. So this is a phosphate-wasting renal tubular acidosis, where patients will have sort of subacute onset of kidney injury that is in the setting of glycosuria, proteinuria, and phosphate wasting. It is much more common from TDF, tenofovir disoproxil fumarate. That's the agent that's in Truvada. Much less common from TAF, or tenofovir alafenamide, which is in most antiretrovirals now. So again, this is quite uncommon. I would say over the course of my career, I have seen 3 total cases of this. We are sometimes concerned about it, but it is very seldom a real acute issue for most people. Sort of with that, if somebody is admitted to your inpatient service and has acute renal failure, we might consider holding their regimen for that reason to prevent Fanconi syndrome. But the reality, bullet point number 5 here, is that a single day with or without ART is very unlikely to cause a problem, right? So people feel compelled to make an emergent choice in the middle of the night when they're admitting someone, or on a Friday afternoon in their clinic when there's nobody else for them to call. The reality is 1 or 2 days of indecision is very unlikely to cause a problem for somebody, right? So if you are not sure, take a moment, phone a friend, call me, right? And come up with a plan that way, rather than sort of making a, shall I say, rash decision. The other time this comes up, and I think addiction medicine docs are really, really attuned to this, is a scary new drug-drug interaction. What do I mean by that? Well, there's a lot of them, most commonly with the boosted protease inhibitors. But I think as addiction med docs, you all are pretty attuned to drug-drug interactions, right? Because your local ID consultant loves to just throw people on rifampin and like not ask whether or not that's a good idea before they did it. And so I think we all have a little bit of a spidey sense for these sorts of things. So sort of imagine that drug-drug interactions may be an issue. The Liverpool HIV drug interaction checker is a really indispensable resource. It has a phone app. Please download it. The other really important thing, I know most folks really learn this back in medical training, please never hold a single agent. That is the one thing you can do to make me, the HIV provider, really angry and upset, right? Hold the whole regimen or not at all, right? Don't hold parts of it. That is when we run into trouble, all right? Question number 2, the converse of this. Should I start this patient on ART? And the answer is almost always yes, right? This is another place where we need to sort of push ourselves. What do we know about immediate initiation of ART? The START trial, this was done in 2015, a little bit of time ago, showed a 57% reduction in risk of serious events or death with immediate initiation of ART, so within 7 days of confirmation of diagnosis. Please don't wait. Don't put in a referral to your local HIV clinic or something like that. Please just start them on ART. It is okay. I will be so happy that you did, right? I will call you and be like, good for you. Like, you just, you just went for it, and like, maybe not the regimen I would have picked, but everything's going to be fine. This patient's going to do so much better for it, right? Don't feel badly about it. But really, the risk of deferring ART initiation is very, very real in most patients. When should we not immediately start ART? There are really a very small number of times. And it's really if you have a concern for an intracranial opportunistic infection. So please, when you meet a patient with a new diagnosis of HIV, do a good review of systems and do a head-to-toe med school OSCE exam, right? Imagine you're being graded on this physical exam. Like, do a full neuro exam, test their Romberg. Hasn't it been years since you've done that? But really, really reassure yourself that there's not anything scary going on. Feel for lymph nodes, look for thrush, right? All of those sorts of things. If you have a question in your mind, like maybe this person has cryptomeningitis, then starting ART right now is probably the least of that person's problems, right? If you have a concern for an acute intracranial OI, then you need to partner with this patient to get them to the hospital, right? That's sort of the important thing. Active TB as well, right? We continue to see this. Please have a high pretest probability for this. One of our infectious disease doctors at our community hospital recently discharged someone with active TB that was untreated because she said, so unlikely in this day and age for this person to have active TB. Surprise, surprise, all 3 smears were positive. And the patient immediately left and got on a bus to New York. So please have a high pretest probability. This does still happen. And similarly, think about patients' visual acuity, right? So CMV retinitis is really the other major reason we would defer initiation of ART. If you do a good head-to-toe exam and you don't find anything abnormal, please just start them, right? Start them right now and connect them to care. What about injectables? Oh my goodness. So should we be starting folks on injectable ART? Could I see hands of folks who've managed folks on injectable ART? Oh, I love this. It's so good. Long-acting cabotegravir rilpivirine, which is Cabenuva. This is an every 1 or 2 months injectable ART regimen, fully injectable, no orals. It has really only been studied as a switch regimen. So the initial trials, Atlas 2M, and Flare, all looked at people who'd been suppressed for 6 months on oral ART before they switched. And certainly we're using it a ton for folks in that situation. What about viremic patients? What about our patients who've never been able to engage in oral antiretroviral therapy, right? In the substance use world, we disproportionately see folks in this situation. And this was a summary slide from CROI this past year in Denver, where they summarized the 4 case series so far of initiation of Cabenuva in viremic patients who had never been on oral ART, and it was disproportionately folks with significant substance use disorder, unhoused in sort of really chaotic living environments. The most impactful was the second one. This was the San Francisco Ward 86 study by Monica Gandhi's cohort, where they started 57 people. Their median CD4 was 215, right? So most people met a diagnosis of AIDS, many of them with high viral loads. And they had a viral suppression rate of 95%, which is really, really incredible, right? When people fail, they develop resistance, absolutely. And you have to be able to find them, right? So they were dosing the 2-monthly regimen, which has a 7-day window on either side of your next injection. And so essentially what they would do is they would send a nurse case manager starting 7 days before the dose out into the streets to find the patient. And they had a 14-day window to find the patient and get the injection, right? Really resource intensive, 95% virologic suppression rate in people who had never been on ART, right? Life-saving intervention. When Monica Gandhi presented these initially at CROI, the ID community like flipped out at her, and she gave an impassioned speech about how none of you all are doing the work and I am doing the work and this saves lives, right? So I spend most of my days trying to get on her level. And actually, after these were presented at CROI, Paul Sachs at the Brigham authored this really fabulous update to the IAS USA guidelines, saying that we may consider initiating Cabenuva in people who are viremic, who have exhausted all other options to take oral ART and are at high risk of HIV disease progression. So up in Lawrence, we have started 2 people already who are viremic, and they've both suppressed. Again, it's resource intensive. You need a lot of resources to find these folks and get them their injections, but it is potentially life-saving for people, right? Nobody wants to have AIDS, as it turns out, but taking pills every day is really burdensome for folks who are continuing to have use. Which leads us to question number 3, is Biktarvy really always the answer? That is the question I get from many an addiction med colleague, and the answer is usually. Why, oh why? I feel like all my addiction med friends feel this way, right? They meet that new diagnosis and they're like, should I just start Biktarvy? That feels too easy. Am I overthinking it? Am I underthinking it? What should I do? And I am here to assuage your stress about this. Biktarvy really is that amazing. Why is it so great? Biktarvy is a single tablet regimen with bictegravir, emtricitabine, and tenofovir alafenamide. It is potent, it is well tolerated. It has a very high resistance barrier, which means that it is very forgiving of missed doses. We don't tell patients that, of course not. But there are data out there that people can maintain virologic suppression with as few as 3 to 4 doses a week of this medicine. And I will say anecdotally, I have seen that. We recently came upon a patient in my HIV clinic. She and her husband both have HIV. They're both on Biktarvy. One of them had not been insured for about 6 months, and they had split their Biktarvy between the 2 of them for 6 months. So they were each only taking half of it, and they were both still suppressed after 6 months of that. And I was like, okay, well, please stop doing that. But let's get you your insurance. And so, you know, for folks who really struggle to take a daily pill, this really is a fantastic place to start. It also provides coverage for Hep B. If you're not sure if someone's Hep B status, it can be started without a baseline genotype, and it is really effective at high viral loads and low CD4 counts. There are few select scenarios where this would not be my first ART to start, and it's really people who have multiple treatment failures. In particular, people who have failed raltegravir or elbaptegravir. So they were on earlier integrase inhibitors, or they were on Apretude for PrEP. So this is the long-acting injectable PrEP. Again, in those cases, right, almost always we can use Simtuza, which has boosted darunavir. But if that is sort of beyond your level of comfort and expertise, just phone a friend, right? We are out there, we're willing. The National Clinical Consult Center, NCCC, which is the HIV warm line through UCSF, They are available to provide expert consultation. Call them if you're out in the world and you don't have access to anybody. Their medical director was actually a former doc up at Lawrence, so please give them a call. Question number 4, literally any question about hepatitis C. Yes, just treat them. I'm not going to belabor this. Come have lunch with me. Could I see the hands of anyone who is aware of an absolute contraindication to treating hep C? Look around the room. Great. This is how I sleep at night, knowing that I treated someone's hep C without any labs today. Why does this matter? Part of it is experience, right? So up in Lawrence, we started treating folks with hep C as soon as DAAs came out in 2013. We estimate we treated on the order of 95% of all people with hep C in our community. We have treated close to 1,000 patients. And our requirements for treatment now are that you have a positive viral load and that's it. Our goal is that patients leave the building with their first month of meds in hand their first visit. It can be done. It requires a lot of work. I would love to talk to you all about it. For folks going to MRSA, Natalie and I are going to be presenting a bit about this, right? How to start hep C treatment in any situation, right? Standing on your head on the mobile unit at 9 o'clock at night. Yes, it can be done. But please, please, please just do it. Don't wait to do it. Question number 5. This actually is probably question number 1 that I get. I'm confused by these syphilis labs. And the answer is us too, probably just treat them. Why does this matter? Why is syphilis testing so confusing? Also, real talk, this is a real poster from World War II. I love it so much. I tell all my friends this. I'm like, yes, everyone has syphilis. I'm like the gym teacher in Mean Girls. So why is syphilis testing so confusing? It's because Treponema pallidum is a really challenging organism. It can't be cultured. It has few antigens on it. And the tests we use to look for it are really tests that have relatively bad sensitivity and specificity. And all that they are doing is changing the likelihood syphilis exists from our pre-test probability to our post-test probability. And not actually telling us whether it's really there. And the other piece that's really important is that there are 2 different algorithms to testing. There's the traditional and the reverse algorithm. Could I see hands of folks who know if they use traditional or reverse? Wow, that's not many people, y'all. You gotta find out. So it actually matters quite a bit whether you screen with a treponemal test or a non-treponemal test. The other thing, right, RPR, the test was invented in 1906. What has changed since 1906? A lot of things. It is not a good test. It is really inaccurate. I saw this fabulous session by an ID doc at Hopkins who was talking about challenging syphilis cases, and one of his recommendations, if the RPR doesn't do what you expect it to do, repeat it in 2 weeks. It'll probably be different. It doesn't respond or behave appropriately in up to 40% of cases. So we need to remind ourselves that RPR is a really challenging thing to manage. The other piece, and we see this in Lawrence all the time, people can be incidentally treated without realizing it, right? So you were admitted for 2 weeks of ceftriaxone for pyelonephritis. You got 21 days of doxy for Lyme disease. You chaotically take a couple doses of ampicillin from the bodega every time you have a runny nose for the past 40 years, right? We see this all the time in our clinic. And the other piece is we were all taught to like desperately wring our hands about neurosyphilis. Again, do your med school OSCE neuro exam. Neurosyphilis is never just memory loss. They will have neuro findings if you do a good neuro exam, right? So please, 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 get in your head about the test, but also don't get in your head about the tests. And if you are not 100% certain this person does not have untreated syphilis, please just treat them again, right? 3 doses of Bicillin is not that big of a deal. Okay, question number 6, as we're coming up to the end, can I treat this infection with oral antibiotics? And the answer is almost always yes. So I'm going to talk to you a little bit about the data. When are IV antibiotics really needed? Most of the data on this are old, they looked at crappy antibiotics, like these original oral sulfonamides and like cefprozil and things that haven't been available in 35 years. And so the data around our recommendations to use IV antibiotics, in particular for osteomyelitis and endocarditis, are really, really bad. What do we actually care about? So when we think about osteomyelitis, first of all, it is standard of care in children to treat osteomyelitis with oral antibiotics. We've done that for years in kids, and the adult literature has just never really caught up. What did we actually find when we studied this? So in the OVIVA trial, which was really a large RCT, it mattered quite a bit if you picked an antibiotic that has good bone penetration, and that was what mattered. What antibiotics have good bone penetration? Quinolones, clindamycin, sulfonamides, tetracyclines. So if you think the infection can be covered by one of those classes, you are pretty good to go. Patients in OVIVA got 7 days of IV antibiotics before they transitioned. So ideally, the folks will get a couple of days if you're following the trial. And the other thing was that OVIVA excluded people who had hardware, right? So the moment someone has hardware, all bets are kind of off because the reality is the hardware probably should come out, right? And it doesn't matter if they're getting IV or PO antibiotics in that case. What about endocarditis? This is the hardest one. The POET trial sort of looked at this partial oral versus IV antibiotics. All of the patients here got 10 days of IV antibiotics, and then they transitioned to 2 medicine therapy based on what the organism was. So for example, folks who had MRSA, they were generally discharged on linezolid plus rifampin, or linezolid plus Bactrim. So you need to look at the trial to see what regimens were used, but they can be used. The other big thing, prosthetic valves were excluded from this trial, right? So again, if somebody's got an infected prosthetic valve, we're really in a different situation. The other bullet point I get here, and this is actually the question I get most often, but it's just a really bad infection. They were really sick. They were septic. Like, I don't care. Like, give them oral antibiotics. This idea that IV antibiotics are better is like a fallacy. It's made up. It is not real, right? And we have to disabuse ourselves of that notion, especially if patients are like, it is intolerable for me to be in the hospital any longer, right? Don't trap people there because you just vaguely feel like IV would be better for a day. Like, that's not real. So just do it. And in my final 2 minutes, what are my last 4 items? This is how I'm cheating. What are the highest impact ID interventions we can actually offer? Thing number 1, vaccines. I picked my 3 favorite vaccines for folks who use substances. PCV20, pneumococcus remains the most likely reason for people to die who use substances in this country. Please, please, please get them a pneumococcal vaccine. So many of our patients who use substances also have diabetes and cirrhosis and cardiovascular disease, so many other medical problems. One and done, they never need another pneumococcal vaccine. Item number 2, Hep B, right? The neglected chronic viral infection, which I declined to talk about today because it is complicated. Hep B vaccine, get it out there. There are newer, more antigenic formulations. If you're not using Heplisav or Prehevbrio, talk to whoever at your clinic gets you your vaccines, get the newer, fancier ones. They work better. They're more likely to produce immunity. And HPV vaccine, oh my goodness, there are unbelievable data that a single dose of HPV vaccine essentially eliminates the risk of cervical cancer, right? We get in our heads because it's going to be you know, are they going to come back for the other 2 doses? How is that going to work? It actually is okay if they just get one. An HPV vaccine is now covered by insurance until age 49 in Massachusetts. Your clinic vaccine manager will tell you that that's a lie, that that's not true, that you're hallucinating, etc. Please push back. Call your pharma reps. They will help you sort this out, but it actually is approved and will be reimbursed by insurance. Item number 8, doxypep. Hands of folks who are prescribing doxypep. Right, we're not to everybody yet. What is doxypep? Doxycycline prophylaxis against bacterial STDs. This is 200 milligrams of doxy taken up to 72 hours after an unprotected sexual exposure, 90% reduction in chlamydia, 60% reduction in syphilis, 40% in gonorrhea across multiple cohorts. large studies. This was added to the CDC's STD guidelines this year as a strong recommendation. There are gaps in the data in a couple of different ways, but overall, this is an unbelievably impactful intervention. I am handing it out like candy, bottles of 50 at a time with 11 refills. And I basically tell people, if you get through a whole bottle, it's probably time to do STD testing again. And let me tell you, people get through that whole bottle. And it is really fantastic. These are the data from the New England Journal DoxyPEP study. They looked at folks both with HIV and folks on PrEP. And you see these unbelievably dramatic reductions in incidence of bacterial STDs, essentially eliminates the incidence of chlamydia, which is unbelievable. And then what do we have next? Think about preventing HIV. Y'all, we have unbelievably effective interventions for HIV, and yet every single week in my HIV clinic, I have multiple new diagnoses of people who either were never offered PrEP or never managed to get it, or there were just so many barriers to them getting it, right? This is a place that we love to wring our hands. Oh, they haven't had the labs. They're not going to come in. I'm so worried. I'm so worried. I get it. Just give them the meds, right? Just get them to them. We need to be innovative too, right? For folks who are using substances, taking a medicine every day is really challenging. Of the three PrEP medicines, Truvada is really the only one that has been studied for prevention of percutaneous exposure, right? So Apretude is approved in people who inject drugs, but who also have sexual exposures, and it was not studied to look at percutaneous exposures. So it's really just Truvada that we've got, and it's really only studied on a daily basis. The thing I think that we need to watch for, so lenacapavir, which is this novel capsid inhibitor that's approved for treatment-experienced people with HIV, it's given as an every 6 months subcutaneous injection. Gilead just announced the results of their phase 3 trial, which showed a 100% reduction in HIV incidence with lenacapavir, and they've submitted to the FDA, so we will likely have this for PrEP within the next year. I think that is going to be the game changer for our folks who use substances. So I think the moment that lenacapavir is available, jump on top of it, be early adopters, and get it available to folks. In terms of PEP, right, like accessing PEP within 72 hours of an exposure is really hard. And so we talk a lot about PEP in pocket. There are whispers of a single dose Biktarvy for PEP study that is currently recruiting. So get the medicine into people's hands. And item number 10 in my last 60 seconds is the thing that we are all already doing: alcohol, pads, clean works, clean places for folks to use, safe supplies, and education about infections. So thank you.